Un saludo muy especial de parte de la Junta Directiva de la Regional Cundinamarca. Le saluda Julieta Castro. Yo soy secretaria de la Junta Junta Directiva de la Regional Cundinamarca, y hoy tenemos pues un conferencista muy especial, el que nos tiene reunidos, y gracias a nuestro moderador, a quien voy a presentar, y agradecerle a él tener el contacto para poder tener esta experiencia del día de hoy. El doctor Juan Carlos Beltrán, que es pediatra de la Universidad de Rosario y quien además trabaja en las unidades neonatales de la Clínica Colsanitas y de la Clínica Country. Doctor Juan Carlos, muchísimas gracias nuevamente por darnos la oportunidad de tener este escenario que vamos a compartir hoy, y le doy la palabra. Muchas gracias nuevamente.
Gracias, Julieta. Buenos días. Buenos días a todos. Nuevamente agradeciendo a Ascon por apoyar esta iniciativa. Y pues dado que la jornada es un poco extensa, iniciamos. El tema que proponemos hoy es el de ecografía intestinal, a cargo de nuestro invitado, el doctor Yasser Elsayed, pediatra neonatólogo y director del programa de hemodinamia y ecocardiografía neonatal en la Universidad de Manitoba en Canadá. ¿Por qué hablar de este tema? La literatura ha aumentado desde 1984. Entre varios autores, el doctor J.P. Goldsmith, que todos conocemos en la Universidad de Tulane con sus contribuciones. Entonces, comentábamos, el tema no es nuevo, desde 1984 varios autores, de ellos el doctor J.P. Goldsmith en la Universidad de Tulane, todos lo conocemos por sus contribuciones en reanimación neonatal, en ventilación mecánica, reportó una serie de casos en los cuales la ecografía se convertía en una herramienta importante en el diagnóstico de enterocolitis, básicamente con la detección del gas en porta. Hallazgo que muchas veces, hasta en el 50% de su serie de casos, estaba presente sin que la radiografía estuviese alterada en pacientes en los que se sospechaba enterocolitis. El procedimiento lo hizo en 230 recién nacidos en los que no se sospechaba enterocolitis y en ninguno había gas en porta. Estamos ya en el 2021, hay muchos artículos que mencionan si deberíamos estar utilizando la ecografía abdominal como primera prueba de elección para el diagnóstico de enterocolitis necrotizante. Mencionamos este artículo en el que participa el doctor Rodríguez Fanjul, lo conocimos, tuvimos la oportunidad, nos acompañó a comienzos de año para hablarnos de ecografía funcional pulmonar, en donde pues también básicamente reporta los mismos hallazgos. Y nosotros queremos compartir en nuestro servicio, en la unidad pediátrica, en la clínica pediátrica del servicio de neonatología de la clínica Colsanitas, un paciente en el que con la sospecha de enterocolitis, una radiografía prácticamente normal, se hace la ecografía, y pues es sobre área hepática hasta la porta, y vemos el burbujeo, como lo describe una colega, el signo de la Bretaña, haciendo referencia a ese burbujeo que constituye el diagnóstico de gas en porta. El paciente se le hizo el manejo intensivo y evolucionó de manera favorable. Atendiendo pues las recomendaciones del grupo multidisciplinario internacional sobre ecografía al lado del paciente en neonatología, recordamos entonces que la ecografía abdominal en el punto 7 está considerado, se puede utilizar para el diagnóstico y seguimiento de enterocolitis con un nivel de entrenamiento moderado. Para el día de hoy, entonces, nuestro invitado procedente de Winipeg, en Manitoba, Canadá, me resulta muy especial porque allí tuve la oportunidad de estar 6 meses en la unidad neonatal. En la época en la que estuve, el doctor Rigato con la bata blanca, el doctor Fajardo, todos conocemos al doctor Rigato, sus contribuciones en la fisiología y control de respiración del recién nacido, sobre todo del prematuro, con uno de los primeros laboratorios de fisiología pulmonar neonatal, señalado por la flecha amarilla, el doctor Fajardo, muy interesado en los temas de mejoramiento de la calidad. Al lado de la flecha verde, el doctor Bill Bowman, con sus contribuciones en el tema de isoinmunización RH. Con la línea gris, el doctor Rubén Álvaro, alta frecuencia, ventilación mecánica convencional. Y con el asterisco, la jefe del servicio en ese momento, la doctora Molly Sechia, quien se propuso un mejoramiento académico, desarrolló un programa de mejoramiento académico. Dentro de ese mejoramiento académico, nuestro invitado de hoy, el doctor Yasser Elsayed, pediatra en la Universidad de Al-Azhar en el Cairo, en Egipto, neonatólogo allí en la Universidad de Manitoba, en Winipeg, y fellow del programa de ecografía funcional del Hospital de Sick Kids de Toronto. Él, con el aval de la Universidad de Manitoba y el apoyo de la Universidad de McMaster, ha desarrollado este programa de POCUS Neo. Les recomiendo a todos los interesados en la ecografía funcional ingresar a esta página, no solamente por el tema abdominal, ecografía pulmonar y principalmente todo lo relacionado con cardiovascular y hemodinamia. A continuación la charla va a ser doblada y al final el doctor nos acompañará para la sesión de preguntas.
Hi and welcome everyone. I will discuss in this presentation assessment of gut injury by ultrasound. I will discuss gut injury in general and necrotizing enterocolitis in particular. I have nothing to disclose in this presentation. And I have three main objectives. First, I will discuss triggers and pathogenesis of gut injury. It is very important to understand the intestinal ultrasound markers based on understanding pathogenesis of gut injury. Then I will discuss intestinal ultrasound in details. Then I will discuss the impact of integrating ultrasound to other clinical and biochemical markers, the impact of this integrated approach on clinical outcomes. There is no any single standard diagnostic marker for diagnosis of neck or gut injury. That's why we are relying on our model on integrating clinical, which is the most important, to intestinal ultrasound, laboratory markers, and abdominal X-ray. We need to integrate all of these modalities to understand the underlying severity of gut injury and also to understand the appropriate interventions, including restart of feeding or the extreme, which is surgical intervention. I have sectioned this presentation into three main sections according to the three objectives. The first section is the introduction about the common triggers of gut injury and pathogenesis of gut injury. So we have four main triggers of gut injury. The first trigger is delayed feeding associated gut injury. Second is lymphocytosis associated gut injury. Third is food protein induced enterocolitis, or the other name is cow milk protein allergy. And the fourth type is ischemic gut injury. So let us discuss one by one. The first trigger is delayed feeding associated gut injury. Delayed feeding usually affecting premature infant or low birth weight infant. And delayed feeding might be aggravated if it is associated with prenatal use of antibiotics. This might induce mucosal atrophy. It might change flora phenotype as a mechanism, and mucosal breach by flora might follow. That it might take few weeks. That's why we are usually expecting that few weeks after birth in premature infants, around corrected age or post-menstrual age 30 to 32 weeks. This type of injury triggered by non-ischemic baseline. So prenatal use of antibiotics or delayed feeding is non-ischemic baseline, but subsequently the gut injury might be directly secondary to decreased blood flow or decreased blood supply, ischemia, and decreased oxygen delivery. At the end, the extreme scenarios got necrosis and perforation. So this is the first type. The second mechanism is lymphocytosis associated gut injury. This trigger is not well understood. It might be associated with a viral infection, and it might happen in premature infant and also might happen in term infant. Lymphocytosis associated gut injury or NIC. It could be, as I mentioned, induced by viral infection or aggressive feeding with increased lymphocytes. It is associated with a mucosal breach by flora, usually around 29 to 32 weeks post-menstrual age. Similar to the previous type, the trigger is non-ischemic baseline trigger, but eventually the gut might be exposed to decreased blood flow or decreased oxygen delivery, gut ischemia, gut necrosis, and subsequent perforation as the expected extreme scenario. We may see in ICU one infant affected with NIC, and shortly after that we may see another infant beside this baby developed also NIC with unknown mechanism. It might be induced by transmitted viral infection from infant to infant. The third trigger is food protein-induced enterocolitis, or as known to a lot of our colleagues as cow milk protein allergy. So cow milk might be related to formula feed based on cow milk protein or the milk fortifier that we are adding to breast milk. And sometimes also might be associated with breast milk, especially with mothers on dairy products. It is associated with a high level of eosinophils, which might be recruited to mucosa with thrombocytosis. There is one of the very common markers to differentiate classic NIC from food protein-induced enterocolitis. Usually in classic NIC we have thrombocytopenia, but with food protein-induced enterocolitis we may expect thrombocytosis plus high eosinophil count. Usually the infant with the food protein-induced enterocolitis is more stable. Clinically, there is no significant hypotension, and the intervention in this case should be focusing to change formula or modify formula, not to keep the infant in PO, which might actually trigger more gut injury. Again, mucosal breach by flora at variable time. This trigger is non-ischemic, and at the end, gut injury might be affected by ischemia, but it is usually very mild in this type of gut injury. The last trigger is ischemic gut injury. So it is direct ischemia. It could be acute ischemia or chronic ischemia. It might happen secondary to congenital cyanotic heart disease or decreased blood flow in interrupted aortic arch on hypoxic ischemic encephalopathy. So it is hypoxic ischemia, and if it is associated also with aggressive start of formula feeds, might induce gut injury. Again, it might be associated with mucosal breach by flora about 5 to 7 days after injury. So this type of gut injury expected to happen shortly after triggering by ischemia, especially in acute type of ischemia. This is the only gut injury with the trigger is ischemic as a baseline, and also the disease state or gut injury type at the end is also ischemic. Now we can classify intestinal injury into 4 main categories. Necrotizing enterocolitis or typical necrotizing enterocolitis in low birth weight infant or premature infant. The second common type is compromised oxygen delivery, compromised by decreased oxygen saturation, like in severe hypoxemia, for example, congenital cyanotic heart disease, or severe hypoxemic respiratory failure. Could be associated with severe anemia as well. Could be associated with shock or decreased blood flow. We consider in our unit for an infant with shock to assess gut injury by ultrasound. It could be also associated with hypoxic ischemic encephalopathy. And then we have the third type, intestinal obstruction. And there is 2 types of gut injury associated with intestinal obstruction. The acute or surgical emergency type with twist of bowel, twist of blood vessels at the same time, for example, in volvulus or malrotation. This surgical emergency because if you wait few hours, it might be associated with significant loss of bowel or necrosis. So this condition should be intervened early. Obstruction also might be associated or secondary to strictures, which is not really surgical emergency. The operation might be considered on elective basis. Stricture or adhesions might follow any type of gut injury and usually happens few weeks after recovery from acute gut injury. And we'll discuss that in more details. Then food protein induced enterocolitis, which is not really severe form of injury, and we don't have again to consider MPO or antibiotics in this condition. We need just to modify formula to hypoallergic or elemental formula. Now we need to understand the link between pathogenesis of gut injury and intestinal ultrasound markers. And for that we have 3 main stages. The first is mild gut injury, early gut injury. Then we have severe gut injury. And then we have pathogenesis of adhesions and strictures later on. So let us discuss one by one. First, we'll discuss pathogenesis of the first stage, which is early mild gut injury. And for each stage, early or severe, we'll discuss 3 main changes. Changes related to smooth muscle, changes related to increased secretions or secretory changes, and then vasoactive changes. The musculosa is the most sensitive part of the intestinal wall to ischemia. As we will discuss later, we have 5 layers of intestinal wall. One of them, the most sensitive one, is musculosa. Why? Because the musculosa is receiving a substantial amount of blood flow. Very vascular layer receiving a lot of blood flow. That's why this layer is very sensitive to any type of ischemia. And with mild gut injury, the muscle spasm might happen with increased thickening of the wall. So when we assess ultrasound in early or mild cases of gut injury, we'll see thickening of the intestinal wall or sluggish peristalsis. So the spasm will cause decreased peristalsis and thickening of the wall. And then another change expected to happen in mild cases, increased intestinal secretions. In severe cases, we'll see the secretions outside the intestinal loops in the peritoneal cavity. So we'll see more ascites, which could be complex, significant ascites. In mild cases, the secretions will be increased intraluminal, inside the intestinal loops. And these secretions should be induced by multiple markers or mediators. The most important one is the vasoactive intestinal peptide. What's the value of these secretions? It's very helpful actually to dilute toxins and dilute the other transmitters that might actually affect or cause more ongoing intestinal injury. And then vasoactive intestinal peptide might actually cause more vasodilator or increase the blood flow or hyperemia. So in early gut injury, we'll see more blood flow or hyperemia induced by vasoactive intestinal peptides. Hyperemia actually might help in recovery of gut injury and usually associated with early gut injury or mild cases. Then in severe cases, we may see the same three categories of changes, but with different kind of changes compared to mild gut injury. Regarding the smooth muscle, we'll see more relaxation instead of spasm. Relaxation will be associated with thinning. So we'll see in the intestinal ultrasound thinning of the wall, which is a lead sign and bad sign as well, and could be associated with intestinal necrosis. And instead of weak peristalsis or slow peristalsis, we'll see absent peristalsis, no peristalsis in late stages. Secretions will be increased and will be not only intraluminal, will be also in the peritoneal cavity. And this kind of significant increase in secretions will be induced by bradykinin, induced also by tumor necrosis factor alpha, interleukins, and might cause significant complex peritoneal fluids. Later on, we'll see that this complex peritoneal fluids might induce adhesions and also might cause a stricture of the intestinal loops later on after recovery from the acute stage. The vasoactive changes, early stages, we mentioned about hyperemia, but in later stages of NEC, we'll see vasoconstrictor effect or vasoconstrictor ischemia secondary to endothelin 1, which is very strong vasoconstrictor mediator, and it is very or kind of easy to see that by ultrasound and to differentiate between mild gut injury with more hyperemia and thickening to severe late gut injury with thinning of the wall, no peristalsis, and ischemia instead of hyperemia. What about pathogenesis of adhesions and stricture? With the complex peritoneal fluids around the intestinal loops, this peritoneal fluid might actually dry or organize over time and cause twisting of the walls. And also with longitudinal and circular muscle spasm of the intestinal loops. And this spasm might happen in longitudinal fashion, as you can see, or circular fashion. And this long standing muscle spasm might cause later on during recovery strictures. Muscle spasm might complicate the situation and cause a stricture, and this stricture will be presented once you start feeding later on with intestinal obstruction. So now we understand the three main categories or stages of gut injury according to severity: mild early type, severe type, and also later on after recovery with the acute stage with adhesions and strictures. I have two case scenarios to clarify the limitation of relying only on abdominal X-ray, and also to clarify how we can integrate intestinal ultrasound to clinical assessment, and also to formulate a logical medical recommendation. So we have preterm 30 weeks at birth. 2 weeks later, this infant started to pass multiple frank blood per rectum. CRP was 6, repeated twice, with unremarkable CBC and blood gases. And we have this X-ray here. And this X-ray was interpreted by the pediatric radiologist and also by the neonatologist as hematosis intestinalis. And in the X-ray, one of the main limitations in the X-ray, you may interpret the presence of air between the fecal contents and the intestinal wall as pneumatosis. It might not be really true pneumatosis. And the blood stool might be related to protein allergy, or might be related to any other reason, like rectal injury or fissure, anal fissure, for example. When we did an intestinal ultrasound 6 hours later after the X-ray, the ultrasound actually was focusing on the same area, left upper quadrant, the same area of concern in the X-ray. I can see very good perfusion, normal intestinal peristalsis, movement. There is no any pneumatosis can be seen. So a very reassuring intestinal ultrasound. And we considered to start feeding after that, and the feeding was tolerated without any issue. Then I have another case scenario. Preterm 26 weeks at birth, hemodynamically stable at 2 weeks of age, developed pancytopenia with high CRP. CRP was initially 196 and rising, but no lactic acidosis in the blood gas. And the X-ray, although the X-ray is abnormal, but we can't see any specific marker for neck. There is no pneumatosis intestinalis, there is no portal venous gas or perforation. And then the ultrasound was showing severe gut injury, very echogenic bowel, septated peritoneal fluid, no color Doppler, ischemia by color Doppler. So the markers that are consistent with severe type of gut injury or severe neck. Later on, this infant required operation with substantial part of the bowel removed, unfortunately, due to patchy ischemia and necrosis of the small bowel in this case. Now let us discuss how to integrate intestinal ultrasound to other clinical markers in assessment of gut injury, or the integrated approach. First, we have to emphasize that abdominal X-ray in comparison to intestinal ultrasound is very limited. And we have a lot of literature discussed the limited agreement between different disciplines, including neonatologist, radiologist, at different levels, including neonatal fellows and pediatric resident, with very poor agreement between them regarding assessment of different X-ray markers, nematosis intestinalis, portal venous gas, even perforation, and in diagnosis of necrotizing enterocolitis at the end. And we have seen in our experience so many X-rays reported, as you can see here, by the radiologist as nematosis intestinalis, and the ultrasound confirmed normal or no gut injury, and we considered to start feeding. And we have, for the last almost 4 years, we have all of these infants tolerated feeding without any complications. So we did actually assessment or data analysis for the cases in our unit, and we have seen that ultrasound was normal in about 44% of the X-rays reported as NEC. That's almost close to almost half of the cases reported as NEC by X-rays. And all of these cases refer to point of care assessment. And we consider to start feeding with just short period of MPO until the ultrasound confirmed normal gut performance. We started feeding in all of them, and the maximum, as I mentioned before, could be some cases with the food protein induced enterocolitis, and then management should consider a change of the formula not to keep the infant MPO. We need to integrate between clinical signs, biochemical markers, and the ultrasound. And unfortunately, all of the clinical signs, biochemical markers, are non-specific, including intestinal signs of blood stools, abdominal distension, vomiting, abdominal cellulitis may be more specific and more important. When you have this sign, you have to pay attention because it's very common associated with severe gut injury. Systemic signs could be tachycardia, bradycardia, apneas, lethargy, or temperature instability. Biochemical markers, all are non-specific markers of inflammation or markers of ischemic injury, including CBC, CRP, genomic markers for pro-inflammatory responses, and we are not using that as a routine yet. And then respiratory and metabolic acidosis might be associated with gut injury, or lactic acidosis and neutropenia. Coagulopathy as well might be associated with severe cases of neck or gut injury. We have 4 main watershed areas which might be affected with gut injury more than other areas of the intestine. So watershed areas, just to simplify the physiology of watershed, we have 3 side by side, 3 areas or 3 categories of tissues side by side. We have area number 1, 2, and 3. There is specific blood supply for area number 1 and another specific blood supply for area number 2. But area number 3 is relying on the terminal blood supply from the artery number 1 and artery number 2. In normal situation, there is no problem, but in case of shock or decreased blood flow, the most specific or most sensitive area to be affected with injury or ischemia is area number 3, which is watershed area. So we have the ileocecal area, is watershed area, the hepatic flexure, splenic flexure, and the lower part of the descending colon. Assessment of ultrasound can be categorized into 12 markers. So free air can be seen by ultrasound, although X-ray is reliable to evaluate free air or perforation. Mural gases or nematosis intestinalis can be seen by ultrasound, but one of the limitations that sometimes is very difficult, especially for the beginners, to differentiate between nematodes, intestinalis, and the air as artifacts. Portal venous gases is much easier to detect by ultrasound, and you can detect even mild cases, and only severe cases can be the portal venous gas can be seen on the X-ray. Thickened bowel, and we are using 0.26 centimeter as cut limit for normal bowel thickness as the upper limit, and the lower limit is 0.11 centimeters. Below that is thinning of the bowel. Again, thickening is early sign, thinning is late sign. Peristalsis can be assessed. You cannot assess peristalsis by X-ray. And intestinal signature, and we'll discuss that later. And we may see fluids. Fluids might be complex fluid or just mild simple peritoneal fluid. By applying color Doppler, we can see good perfusion. And if you see 3 to 9, at least 3 to 9 speckles, this is normal. Color Doppler, speckle of color, by applying 2 by 2 color box. And then if you see hyperemia, which could be different types, can be Y-shaped hyperemia, or circle hyperemia, or zebra hyperemia. 3 main types of hyperemia. If you apply color Doppler and you cannot see any color at all, this can be considered as a sign of severe ischemia or absent color flow due to severe ischemia. So we have the 3 categories. We categorized ultrasound for simplification into 3 main categories. You can differentiate between jejunum and ileum by ultrasound. So the jejunum is occupying the left upper part of the abdomen. The jejunum is mainly the lower right part of the abdomen. The ileum is smooth from inside, as you can see here in this image with dilated ileal loops. It's abnormally dilated, but just to clarify that the ileal wall from inside is more smooth compared to jejunum. Jejunum, you can see some ridges, and these ridges are representing intestinal villi or plicae circularis. And the plicae circularis will give the impression that the jejunum is more thicker by ultrasound, but should not exceed the upper limit of normal, which is 0.26 in even term infant. In this slide, we'll discuss how to perform ultrasound as a technique in brief. So we can divide the abdomen into 4 main compartments, and also we can add the periumbilical area or midgut area. So the abdomen is right upper quadrant, right lower quadrant, left upper, left lower, and it's very important to evaluate the liver for portal venous gas. With ultrasound, we need to apply the ultrasound probe in 3 different planes: the sagittal plane or longitudinal plane, the transverse or cross-sectional plane, and the coronal, or from the side, the coronal plane. So you have the sagittal, the green plane is transverse, and then the coronal plane from side to side. The sagittal and the transverse planes are the most important in assessment of liver. So assess the right lobe in both longitudinal and or sagittal and the transverse. Left lobe the same, longitudinal or sagittal and the transverse. And we need to assess for any evidence of portal venous gas in the liver. And if you see any abnormal thrombi or any abnormality in the gallbladder or so, you need to refer that to the radiologist to do like more detailed assessment by the radiologist with full ultrasound of the liver compartments and the structure. And also you need to assess the right upper quadrant and all of the other quadrants in sagittal and the transverse planes, and also the periumbilical area. The colon, the ascending colon and descending colon, they are more lateral or to the side. So you need to move the probe to the coronal plane to see the colon and the longitudinal section, or you move the probe transverse, you can see the colon as circles. It is easier to assess the ascending and the descending colons. Transverse is more difficult because the shadow from the air in the stomach, but you can see the hepatic flexure and splenic flexure easier by ultrasound. Now let us discuss the intestinal ultrasound markers one by one. So we have nematosis intestinalis, portal venous gas, peristalsis present or absent, or maybe slow peristalsis, intestinal signature, intestinal wall thickening or thinning, assessment of perfusion by color Doppler, presence of peritoneal fluids or ascites, perforation, although it's better to assess perforation by X-ray. And then if you have near-field spectroscopy, also you can assess gut ischemia by adding near-field spectroscopy to ultrasound. And then we need to differentiate between true nematosis and false nematosis. As you can see here with the nematosis intestinalis, echogenic tiny small bubbles around the lumen or inside the intestinal wall in multiple loops. Also in this loop you can see the typical true nematosis, and also in this multiple loops, abnormal loops surrounded by peritoneal fluids with this loop with severe or significant nematosis intestinalis. Typically with a true nematosis in gut injury, it is almost difficult or should not be seen without any other markers of gut injury. Nematosis should be associated with other markers like peritoneal fluids, ischemia, thickening, thinning. If you see only nematosis or suspicion of nematosis and there is no any other markers with good peristalsis, this is most probably false nematosis or artifacts. So let us see what our artifacts looks like. So here you can see good peristalsis, moving bowel, and there is area here of suspicion. This area with some bubbles, and if you apply the pressure by the probe, you can move easily, see the intestinal artifacts moving away from the this image, which signifying artifacts more than nematosis. So let us see that again. Applying some pressure with my hand, as you can see, the air artifacts disappeared within few seconds. So we need to differentiate between true nematosis in gut injury and false nematosis or air bubbles artifacts because of presence of air inside the intestinal lumen. Then we'll discuss the next marker, which is portal venous gas. Portal venous gas can be massive. As you can see, a lot of bubbles moving in all directions in the portal veins inside the liver, or could be moderate. Less significant bubbles moving also in the liver in different directions, or could be mild. You can see just a few small bubbles moving in the liver. Mild portal venous gas is usually missed by X-ray. You can detect by X-ray massive portal venous gas or even moderate portal venous gas. But this typical case with the mild portal venous gas was missed by X-ray done at the same time. So it is easy to miss mild portal venous gas. Ultrasound is very sensitive to detect even very mild cases of portal venous gas. Then next, let us discuss peristalsis. So I'll just show you a clip with normal peristalsis. You can see the very nice hypoechoic normal bowel with the good peristalsis, which is different from this clip with absent peristalsis. You can see just a pulsation from the abdominal aorta, just pulsation, but there is no any effective movement of the gut, and very echogenic severe gut injury. As you can see, very echogenic bowel due to severe gut injury. And then the other type of peristalsis could be obstructive peristalsis. When you see dilated jejunal loop, as you can see here, and the intestinal contents moving in both directions, back and forth, not effective forward one direction peristalsis. This could be or most probably related to distal obstruction, distal to this loop. So we have now good understanding how to differentiate between normal peristalsis, absent peristalsis, and obstructive peristalsis. Then next we'll discuss intestinal signature. Intestinal signature means that you can differentiate the intestinal wall layers. We have two hypoechoic layers, musculosa and mucosa, and the three echogenic or bright layers. So overall we have 5 layers. First, the mucosal interface. Echogenic layer, it is interface between the mucosa and the intestinal contents. Next, number 2, the mucosa, which is also hypoechoic. Hypoechoic dark in the ultrasound because it is receiving good amount of blood supply, the same like musculosa. And then we have submucosa, more echogenic or bright, and then we have the musculosa, more thickened compared to mucosa and also hypoechoic, and the 5th layer is serosa at the end. If you're able to differentiate the layers clearly, it means you have impression of normal intestinal signature or normal bowel wall, because in ischemia you cannot differentiate between these layers, because everything will be echogenic, everything will be with low blood flow, so the musculosa will lose the hypoechoic nature and will be more bright. Then next we'll discuss intestinal wall. In intestinal wall assessment, we have to differentiate between normal intestinal wall, thickening of the wall, and thinning of the wall. And remember, for any of the previously mentioned markers and the upcoming markers, we have to assess 4 quadrants: right upper, right lower, left upper, left lower, and also you may add the periumbilical area or the midgut. And you have this loop here, the jejunal loop, which is really thickened and measured as 0.35 compared to this thin wall of the colon, which is only 0.09 centimeter or 0.9 millimeter, very thin, surrounded by peritoneal fluid. And also in this abnormal lobe with the thickening, you cannot differentiate the layers because of the significant bowel ischemia. Also here in this thin wall of the colon, you cannot differentiate the layers. It's just one echogenic layer. So we have at least 2 markers can be appreciated in this image: thickening and loss of intestinal signature. Here you have thinning, loss of intestinal signature, and the peritoneal fluids, and also dilated intestinal loop. Remember to evaluate any one of the previously mentioned markers in the 4 quadrants: right upper, right lower, left upper, left lower. Next, we'll discuss perfusion by color Doppler. Perfusion, we need to differentiate between normal hyperemia and the hyperemia, as you can see, Y-shaped hyperemia, and in between very echogenic bowel wall, and you cannot differentiate any intestinal signature here. And also ischemia. Ischemia will be the opposite. No color Doppler can be detected, only some artifacts here, but no typical speckles or even hyperemia. This infant with significant ischemia operated almost 30 minutes after this ultrasound. And with this significant ischemia represented with pathology or during OR, as you can see, discolored bowel with like dark or gray color bowel due to ischemia, and you have different levels of ischemia. This bowel loop here looks pink or normal compared to gray hypoperfused bowel, and other loops here with also gray but less severe ischemia. There is the same infant with this ultrasound performed just shortly before OR. Then we'll discuss ascites or peritoneal fluids next. We have to differentiate between luminal fluid, which is more kind of circle fluids in this cross-section image of colon, and you can see the shredded mucosa of the colon. You have the peritoneal fluid, which is can be differentiated with acute angles or irregular angles of the sides. So that's the peritoneal fluid here, side by side with luminal fluid in this infant with severe gut injury. Next, we'll discuss perforation. Again, remember that perforation is better to be assessed by X-ray. That's why with any infant with the severe gut injury, we'll consider abdominal X-ray to be done frequently to assess any perforation that might happen at any time. So you have in this image here air artifacts over the liver due to perforation, and also you have another image here with air artifacts due to significant perforation. The middle example here is different. The air was encysted inside the bowel, between the bowel loops, and this perforation initially was missed by X-ray, was detected by ultrasound, because the air was encysted, not really free air that can be detected by X-ray. If you have near-field spectroscopy, also you can assess bowel ischemia. But one of the limitations of near-field spectroscopy, that if you are assessing any area with the fluids or air content, you can detect only the reflection of the or perception from the air artifacts, not actually from the ischemic bowel. That's why it's very important to assess by ultrasound first, to be sure that you are applying the probe over tissues or over intestinal loops, not over fluids like here. So here is more reliable because you are assessing area with tissues and there is no fluids or air, so the perception of the near-field spectroscopy will be typically from tissues. not from fluids, as you can see here. And we are relying on both saturation and fractional oxygen extraction. If the saturation is in 60%, in mild cases, less than 50% in severe cases, this is considered as a marker of severe ischemia. But remember that once you have the intestinal loops necrotic or gangrenous, then you should not expect any increased extraction or any even normal extraction with oxygen. Then you may have the oxygen saturation even higher than normal, or almost similar to the arterial oxygen saturation. So with the typical ischemia, you will see low oxygen saturation on near-field spectroscopy with increased fractional oxygen extraction more than 0.3 or more than 30%. And in necrosis or severe gut injury with gangrenous bowel, you will see the oxygen saturation very high and with very low fractional oxygen extraction. If we integrate between thickening of the bowel and the color Doppler, we can actually consider a very nice, reliable grading of ischemia, which has been published. So normally we have normal speckles of color, 3 to 9 as I mentioned, and normal thickness of the bowel. Early gut injury, you can see thickened bowel with hyperemia, or could be thickened with ischemia, which is more late. And then we have thinning of ischemia, or could be severe ischemia. When you see a very thin bowel wall with no color Doppler at all, that could be just a necrotic bowel segment or wall. Now section number 3. So we'll go over the outcome of integrated approach. So we assessed in our unit 144 cases assessed from 2016 to 2020 in 2 hospitals. And we evaluated or classified the gut injury based on the outcome. So if the infant continued feeding with normal ultrasound and feeding was well tolerated, we consider that as normal. Although we have significant number of cases with abnormal X-rays reported as nematosis. That's why we consider that intestinal ultrasound is superior to X-ray in assessment of gut injury before perforation, because perforation, again, we should rely on X-ray. And then if the infant was clinically consistent with food protein-induced enterocolitis, and the formula changed to hypoallergic and the infant improved, or the symptoms improved with the improvement blood stools, abdominal distensions, and biochemical markers, eosinophilia, and so on, we consider that as confirmed food protein-induced enterocolitis. And then if the ultrasound was consistent with early mild gut injury or NEC, and the infant tolerated feeding after variable period of MPO, usually maximum 7 days, 5 to 7 days, we consider that as mild gut injury. But if the infant required surgery later on after improvement due to stricture or adhesions, we consider that as moderate gut injury. But if the infant required urgent surgery due to severe ischemia, severe bowel or gut injury with resected part of the bowel, we consider that as severe type of gut injury. We compared intestinal ultrasound severity score with the classes of gut injury, and the score was significantly higher in severe cases compared to moderate and mild cases, and score of 0 in normal cases. X-ray score, which was based on nematosis intestinalis, portal venous gas, or perforation, did not differentiate between normal, mild, and moderate cases. Only the score was significant in severe cases of NEC. Eosinophil count was reported in literature as a reliable marker of food protein-induced enterocolitis, and the ultrasound score was significantly higher with high eosinophil count, and the X-ray score did not show any significant difference between normal cases and food protein-induced enterocolitis. This slide summarizes the integrated algorithm management for gut injury. If there is clinical suspicion of neck or gut injury, we'll consider gut injury workup, including CPC, electrolytes, CRP, X-ray, and intestinal ultrasound, after consulting the physician responsible for this integrated approach. If the infant is symptomatic but stable with normal ultrasound plus normal lab work, we'll consider to start feeding or continue feeding without interruption. If the infant is symptomatic, stable, with lab work consistent with food protein-induced enterocolitis, we'll consider elemental formula for 7 days as a trial to see if the infant will improve on that or not, and then advocate mother to quit dairy products if she would like to continue breastfeeding and restart breast milk after that. If the infant is symptomatic but unstable with respiratory or hemodynamic instability happening at the same time of suspicion of neck, or with abdominal cellulitis, together with mild ultrasound markers and lab work consistent with neck, will continue MPO for a variable period of time until we have the lab work normalized with normal ultrasound, and then we'll start feeding. If the infant has significant ultrasound markers with or without perforation, we'll keep MPO for a longer period of time until we have the lab work clinically and ultrasound normalized, and then we'll start feeding. Before we started our integrated approach, we had higher than national average cases of neck at St. Boniface Hospital, and we started our program 2016, and after that the trend has been going down, and now it is below the national average. The same for Health Science Center. We were higher than the national average. Our center in blue bars, national average in yellow bars. And after we started our program, now we have very low rate of neck at HSC Winipeg. Now we have 4 main conclusions. First, gut injury is multi-trigger disease with variable pathophysiologic mechanisms. Although abdominal X-ray is helpful with perforation, but it is limited in assessment of the degree of gut injury. Ultrasound is superior to abdominal X-ray in identifying prognostic value and the complication. We have to keep in mind that ultrasound is operator dependent. The same like any ultrasound modality, intestinal ultrasound needs a lot of training and experience under supervision. In this presentation, we focused mainly on intestinal ultrasound assessment of neck and the gut injury, acute gut injury, but ultrasound can be also used in surgical cases, including assessment of volvulus, malrotation, adhesion and strictures, and also intussusception. But all of these indications need to be discussed in a different presentation.